Welcome. I am so pumped you're here. If you're gearing up for that ATI neurologic system quiz and just feeling totally overwhelmed by the sheer amount of information, you are in the exact right place. We're going rapid fire today. I've designed this explainer specifically to give you the 15 key points to pass your ATI. That's right, 15 absolute must-know facts. We're cutting out all the fluff and focusing strictly on the high-yield stuff. So let's just dive right into it. To make this super dense material actually stick, we're breaking it down into 4 high-yield buckets: core anatomy and physiology, master the neurologic assessment, essential diagnostic procedures, and increased intracranial pressure.
All right, bucket number 1, core anatomy and physiology.
Starting off with point 1, the neuron. This is the primary functional unit of the whole system. Now, see that myelin sheath coating the axon? It is definitely not just for show. That myelin gives axons a white appearance, but more importantly, it acts like insulation on a wire, massively speeding up electrical conduction. If that myelin gets damaged, which happens in certain disease processes, that rapid-fire communication just breaks down.
Which brings us to point 2. You absolutely have to know the distinct lobes of the cerebral cortex. The frontal lobe, that's the boss of voluntary muscle movements, plus verbal and written speech. Now contrast that with the parietal lobe right behind it, which handles sensory reception. It interprets pain, touch, and temperature. Knowing who does what helps you actually pinpoint where a brain injury occurred based just on what the patient is experiencing.
Moving to point 3, the autonomic nervous system. You've got to be able to rapidly contrast these two sides. The sympathetic nervous system, that's your fight or flight. It pumps out epinephrine, jacks up the heart rate, constricts blood vessels, and shoots blood pressure up. On the flip side, the parasympathetic system is your rest and digest mode. When that kicks in, heart rate drops and blood pressure comes down.
Okay, Chapter 2, Master the Neurologic Assessment.
Here's point 4. Whenever you're doing a routine neuro exam to get a baseline, there are 4 major things you always evaluate: level of consciousness, pupillary response, neuromuscular response, and vital signs. You're really looking for trends over time here, right? Because one single funky finding in isolation might not give you the whole picture.
Now, to objectively measure that level of consciousness, we hit point 5, mastering the Glasgow Coma Scale, or GCS. You've got to memorize its 3 pillars: eye response, motor response, and verbal response. We use this to objectively score how a patient reacts to stimuli, everything from just a simple hello to a painful sternal rub.
And this brings us to a massively high-yield fact for your exam, point 6. A normal, totally alert person scores a perfect 15 on the GCS. But listen to this, a score of 7 or less equals a coma. Commit that number to memory right now. 7 or less, that means severe neurologic compromise.
Point 7 is all about grading muscle strength, which ATI loves to test. It's a scale from 0, which is complete paralysis, no movement at all, up to 5, which is totally normal strength against gravity and full resistance. You'll literally test this by having the patient push and pull against your hands.
Next up, bucket 3, essential diagnostic procedures. Point 8 focuses on the lumbar puncture. Check out the positioning. The patient has to be in this flexed, kneaded chest position, usually lying on their side. Why? Because curling up like that maximally separates the vertebrae, specifically between L3 and L4 or L4 and L5, so the provider can safely slip the needle into the subarachnoid space to get that cerebrofluid.
Building on that, for point 9, your specific nursing interventions for a lumbar puncture. Before the procedure, always have the patient void so their bladder isn't uncomfortable. And post-procedure, this is highly testable. You must strictly enforce that they lie completely flat for a specific period of time. Doing this massively reduces the risk of getting a severe spinal headache from a CSF leak.
Points 10 and 11 cover your essential prep for 3 other major scans. For an EEG, wash the patient's hair so the electrodes actually stick, and hold off on any caffeine or sedatives for 8 to 12 hours. For a CT scan with contrast, you're screening for allergies, contrast dye, iodine, shellfish. And for an MRI, remember, it is literally a giant magnet, so strictly screen for metal implants, pacemakers, or basically anything metallic in the body.
All right, our final and most critical chapter, increased intracranial pressure, or ICP.
I want you to drill point 12 into your brain. The absolute earliest sign of increased ICP is a change in the level of consciousness, okay? Before the pupils blow, before vitals crash, even subtle things like mild agitation, restlessness, or just being a little too drowsy, those are your very first red flags. Do not ignore a restless patient.
Point 13 looks at late, severe signs, abnormal posturing. First, we have abnormal flexion, also known as decorticate posturing, where the arms rigidly flex inward toward the core. Then there's abnormal extension, or decerebrate posturing, where the extremities are extended stiffly outward. Decerebrate is generally worse, pointing to extensive midbrain or brainstem damage.
Point 14 is another huge one, Cushing's triad. When ICP gets critically high, the body panics and tries to compensate. The triad is three things: hypertension with a widening pulse pressure, meaning the top and bottom numbers of the blood pressure get further apart, bradycardia, and irregular respirations. Mark this down. Cushing's triad is a late, highly dangerous sign. If you see it, it is an absolute emergency.
So, point 15. What do we actually do? Here are your priority nursing measures. Elevate the head of the bed to 30 degrees to help venous blood drain from the head. Keep the neck totally straight, absolutely no flexion. And pharmacologically, anticipate giving a hyperosmolar diuretic like IV mannitol. It literally pulls fluid directly out of the swollen brain tissue and into the bloodstream to be eliminated.
And here's why all of this matters. If we don't catch those 15 points, if we miss the subtle LOC changes and ICP goes untreated, the rigid skull can't expand, so the pressure physically crushes the delicate brain tissue, shoving it downward and herniating it into the brainstem. It is literally a matter of life and death.
So, let's tie it all together with an actual NCLEX-style clinical judgment scenario. This is exactly what you need to be prepped for on your test.
I'm going to leave you with this thought to test your freshly acquired knowledge. A patient with a head injury suddenly develops a blood pressure of 150/68 and a pulse of 58. What late, dangerous neurologic emergency is happening right now? Well, I really hope you're shouting Cushing's triad at your screen right now. That widening pulse pressure and dropping heart rate are classic signs of severely increased ICP. Review these 15 points, keep them fresh, and I just know you are going to completely crush your ATI. Keep studying hard, and I'll see you in the next explainer.